I want to say welcome to everybody to the Queen's Health Services and Policy Research Institute's Inside Research Series. I see lots of familiar faces, and for those who I haven't met, my name is Catherine Donnelly, and I'm the director of HSPRI. I just want to start by acknowledging that Queens is situated on the Anishinaabe and Haudenosaunee territory, and how grateful we are to be here on this absolutely beautiful winter day. We're excited to introduce and have Laura here today, Dr. Laura Rosella, who's here to talk to us about the data, a guide to population health management. And it really couldn't be more topical today as we're planning our new OHT and really as Ontarians and Canadians in this global pandemic. Laura sits on HSPRI's Advisory Council, and I could be here for the next hour highlighting all of her incredible work, but I'll just bring to your attention all the work that she has done. She's an associate professor at UofT's Dalla School of Public Health. She's also the site director of the ICS at UofT and a Canadian research chair in population health and analytics. And if that isn't all impressive, in 2018, she was named the top 40 under 40. Her research is focused in 3 areas: population health, predictive models to support public health planning, and population health management. So we have about 45-50 minutes as she's going to be talking through, but please use the chat and any comments, please add, and we'll have lots of time at the end to ask Laura some further questions. We'll be also recording this and putting it on our website and YouTube channel. And Laura, I hand it over to you.
Thank you, Catherine, for that very nice welcome and for inviting me. I'm going to put my slideshow on. Is that working okay? I never quite know how it's going to work out. And also thank you, Sherry, for doing such an amazing job organizing these sessions. And it's such a pleasure to be here to speak with you. And I'm going to talk about how to use data to inform population health management, which I know is all top of mind as we start thinking through OHTs. And I know how hard it is to pay attention on Zoom. So I'm going to give you the conclusion of my talk right up at the front, and then we can talk through it in a bit more detail. The idea is that we have a system where we have this great rich population health data, and we're using that to guide the management of the health of a particular population. And the latest version of that in Ontario is Ontario Health Teams. But I would say we're not at a point where we can do that just yet. There's some pretty big gaps that we need to fill, and I think we can do it, and we can fill them. And right now we're sort of meandering our way into doing more regular population health assessment and figuring out what our population is, and that's feeding in. But I'm going to suggest that we need different types of data to do population health management, and we need to think hard about how to implement it, because we've actually never done it before, and we don't have a lot of great examples of how this is done in the health context around the world. There are some jurisdictions starting to do this well in smaller scales, so we're embarking on new territory here. A little bit about my background. I run something called the Population Health Analytics Lab, and the reason why I'm telling you this is because this is what we try and do. We take lots of data on lots of dimensions on social, behavioral, environmental, and health, and we try to understand how that risk is distributed in populations, and then use that information to help inform better strategies where we're matching interventions and resources. And that's kind of the spirit behind the population health management approach. So I will start with talking about segmentation approaches, getting a little bit into the methods, the actual methods we need to implement, because I think that's important. There are some pretty important differences in these methods, and we're doing some research on testing different methods, so I'd like to share that with you all. I'm going to focus on data and implementation, as I said on my first slide, as some of the key areas that I would love some focused effort and vision on to get us to truly achieving population health management, and some recommendations and take homes. So a little bit of context, and I think that there's a lot of complexity in Ontario. So I know, many of you know, I know many of you work in Ontario. I think we think population health management as a concept that's well defined, and we just have to figure out how to implement it, when in fact, there's a lot of big things we need to work through, and every jurisdiction is grappling with different contexts. But what's our context in Ontario? So before COVID, I would often talk about this idea that we have two health systems, really. We don't have one health system that integrates public health and healthcare together. Many people, when I speak to students for the first time, they aren't aware about. I remember when I learned this from the first time, sitting as an undergrad trying to learn about the health system in Ontario, and not realizing that they were actually quite different and didn't necessarily speak to each other. I think we've learned a lot through COVID on how we can integrate these systems together. And in fact, jurisdictions and countries that are building health systems, they build it with integration from the start. They build primary care as a strong base for very good reasons, and they build in public health integration from the start. So that's something we have to grapple with, especially if we're going to try and do population health management. And there are some structural barriers here. It's not about people not wanting to work together, or that's your thing and this is my thing. They are funded differently. There are governing structures that are quite complex. And until we actually sit down and think through how we can address some of these barriers, they're going to remain a barrier for any type of population health management that we would like to do. And the other challenge and context is that we have interventions at various levels. So in our healthcare system, we're really focusing on interventions that can be deployed to individuals, really important interventions for improved outcomes and quality of care. And ideally, if those interventions are applied to the population equally, you could have population impact. But in fact, there's another layer here in that in the public health framing that you focus on factors that cut across populations, structural factors, environmental factors, and variation that can happen within and between groups. And the idea is that if you work on those factors, you will have population health impact. So the idea is to somehow bring these concepts together. And this is just a piece that most recently, I had the pleasure of working with a few colleagues from the University of Pisa, who, if you are familiar with their work, they are, gold standard in Europe for population health system management, I should say. And so we did a bit of a review on performance management and noted a bit of an evolution. And I would say that this evolution also mirrors our evolution in thinking about how it's important to think of population health. So initial population health management starting with budgetary control, then slowly moving towards saying we need a multidimensional view of the health system, bringing in the patient voice. We're now at the part where we're starting to say, well, actually population health issues matter. We're talking about health from a broad perspective and societal impacts, and then really focusing on resilience. Do we have resilience in our health system? And obviously COVID has taught us about that. So this sort of mirrors this evolution that's been happening. I do want to mention resilience just in a bit more detail, because this is something that is not formally integrated in most population health management thinking, and actually even population health management period. There's a little bit of sprinkling on it. But the idea that as a system, if you want to manage the health of a system, the ability to absorb shocks to that system is really critical. And the other thing we know about health system resilience is you can't just assume it's there. Actually, you should assume it's not there. Most of our systems are maxed out. And if we're optimizing a system to perfection and we don't leave wiggle room for resilience, it's going to be a challenge. And so that's something one of the take homes of the talk today is how we're actually thinking about resilience when we think of population health management. Are we building it in from the start? And just looping back to population health, this means thinking about our community, because resilience of a health system is as much about the resilience of the health system as it is about the resilience of the community that uses that health system. And what are we doing to make sure that the community is actually resilient? And not to make this talk about COVID, but that's sort of in blaring lights in COVID. And in all of these actual emergencies that are pictured here, when there is the post-hoc report on them, number one will say how important it is to have the community involved for Ebola, for Katarina, making sure that the community is involved and engaged to that response from the start. And those relationships don't just happen. So they have to be built in before the disaster strikes or the public health emergency strikes. And so last, before I go into the segmentation approaches in a bit more detail, this is a graphic that some of you may have seen and some of you may not have, by Struge et al. And it's really talking about health system transformation and population health management, and just reiterating the idea that what we're talking about here is monitoring our population, doing our health assessment, and then some kind of risk assessment. And that risk assessment has a very wide breadth to it. For everything from health promotion and wellness up to disease care and management. It has a policy layer as well as an individual health interaction layer. And as highlighted also in this graph, I just want to point out is the strong base of primary care, which I do believe is a really important part of population health management. So first and foremost, what's the population? This is my favorite question, because I think it seems like such a simple question. Who's in, who's out? And in some jurisdictions, again, depending on how their health systems are set up, it is actually a straightforward question. There's a population enrolled, for example, or it's geographically based, so it's very clear who's in and who's out based on where you live. Ontario, this is complex. And I'm just going to go through a series of pictures, and everybody, again, knows this, we live it, but sometimes I just sit back and appreciate how complex things actually are. So we have 35 health units, which everyone now really appreciates how important their role is. They have boards of health that actually not a common board structure. So there's complications there. They line up to municipalities to some extent, and they have strong relationships with municipalities, which is a good thing. We have LINs going through this transition period, as we know, for many, many years, which are organized based on how people use healthcare. Lots of discussion about that. We have over 140 hospitals. We have 450 other healthcare institutions. They also have their own boards, and their borders don't align at all with the health unit borders that I mentioned earlier. We had sublins for a brief moment of time, and functionally, actually, some jurisdictions actually do use sublins for planning purposes. So that's just on the health side. So if we were to say, who's your population? None of these definitions actually overlap, align. And if I'm talking about a vision of population health management where we're understanding the broad ecosystem, we have to think through how all these different actors are going to work together. But what if your focus is not health at all? There's 444 municipalities in Ontario, and there's school boards, and there's cities where people work, live, where they go to school, where lots of other aspects of their life are really critical and based, and where the funding for those services actually live. So all this to say, when we think, whoops, Siri's talking to me. All this to say, when we think about what our population is, we do have to think through the implications of not following any of these particular definitions. None of these, of course, are perfect, and they're complicated. But this is where I think some more thinking is worthy of some time. So this is an example. I'm a chair at Trillium Health Partners, and very excited to be working with the Mississauga, Ontario Health Teams, fantastic group of people. And this is just a schematic of our population. So we have several hundred, so over 700,000 people that live in Mississauga. And we have an attribution methodology which we follow based on being rostered to a particular physician. And again, the methodology is very strong. You can understand the basis of the methodology in terms of why we'd want to roster the primary care physicians or a responsible physician. But then there's that piece about where they live and all of those other aspects that become a big challenge. So most of the population live and are rostered there. Some live but are rostered somewhere else. Some are not rostered at all. Some live somewhere else, but they're rostered in. Some don't live or are not rostered, but they are receiving care from our region for whatever reason. So it's really complicated. And I know all of you are experiencing this and grappling with what does this actually mean? Well, the main issue that might come up with these types of definitions, and it would be great to hear how others are coming against this, is how this connects to community services, to schools. How does this affect health promotion, equity, and policy issues? And that's where I think the big challenge is. It's not an insurmountable problem, but we have to recognize it and put in strategies to make it easy. Because if it's not easy to work with schools and community services and health units because the boundaries don't line up, then we won't do it. So given that that is our challenge, how can we make it, how can we facilitate it? How can we address it? We have to put a plan in place and address it. Or are there other considerations for populations definitions to make these issues more an important focus? And going back to the Struge article, you know, just really emphasizing that in order to do population health management, we're always acting on multiple levels, and each level is critical. The micro level, focusing on high-risk individuals who need lots of complex coordinated care. The meso level, maybe, you know, individuals living with diabetes, for example, something a bit more broad. And the macro level, are there policies, are there structural issues that need to be addressed that affect the whole population? So let's talk briefly about the actual segmentation approaches, the using the data, and how we use this to inform management. So the most common approach is to use population segmentation. Many of you would be familiar with this concept, and it, you know, very popular in marketing. The idea that you have, that's sort of the roots of it. You have a group of individuals and you segment them into health status, to needs and priorities. And by grouping them, you're able to better match what you need for these particular individuals. And then there's this layer of accountability in there. If you're accountable for this population, if we're saying this population's yours, you're responsible before they get sick and after, so there's a trajectory there, then you're going to want to optimize at all phases of that trajectory. And we generally, again, think about these three approaches, that you have an approach that affects the whole population. And this is where the definitions become really critical, because if I'm talking about a policy or legislation or something else that we want to implement, then let's take, again, COVID and mask wearing. So that's a municipal bylaw that's going to be implemented, right? But if you have 8 municipalities in your Ontario Health team, then you have to think that some can implement it and some can't. If you have to work on legislation, you might have to do it in some jurisdictions and some not. So this is where the definitions are actually critical. It's for the whole population approaches. And then you have subpopulation and high risk, as I've mentioned earlier. And one thing I am going to emphasize a few times is this idea that within each of these segments, there's variation. Always within the segment, there'll be variation, and between the segments. And so we're pretty good about the big segments, understanding which groups have particular needs and bucketing them. And then there's this extra layer of what about within those segments? What are the factors that really affect the ability of a person to respond to an intervention, to be offered the intervention, barriers. And so that's an extra piece that exists in all segments, especially for the subpopulation and high risk. So that's something really important to keep in mind. And sometimes the whole population approaches intersect with those, because if it's a whole population approach that's improving equity, it will also hopefully improve equity overall and within the segments of the population. So the question on many people's mind is, how do we actually do these segmentation approaches? There are many approaches, so I won't tell you about all the different ones, but really just talk about two common approaches at a high level, and there's some overlap between these two to give us a sense of which one should we use and why, or is there some combination? Because I think many jurisdictions are trying to figure out what's the best segmentation approach that they could implement, which is good. It's great that health systems are thinking this way. So the most common historically have been this sort of expert or consensus driven. So you'd have ranges of conditions or segments that experts have defined as being meaningful. Perhaps they're clinically meaningful groups. Health system administrators recognize them as groups that are resource intensive, for example, and these groups are roughly defined. And then it involves digging into the data, which again, I'm going to talk about in a few minutes, and defining diagnostic patterns of use based on these data. And once you find these meaningful groups, there's additional steps, which I didn't put here, about putting weights to them in a particular way to help you understand how to use them. So perhaps some conditions, you have an unstable chronic condition that needs lots of care, that has a higher weight than sort of an acute, sort of low acuity condition that just requires 1 or 2 healthcare visits. So this is, Johns Hopkins ACGs, and there's many other sort of off-the-shelf tools that have been developed to run on routinely collected health data so that you don't need to put in a data system in place. It runs on the data you have. You can understand and segment your population. So that's the one of the most common. More recently, you are seeing these data-driven approaches. So these approaches don't start with a predetermined, for the most part, they could have rough predetermined, but for the most part, they don't start with a predetermined, well, these are our segments, these are the ones that we know are important. Instead, they use the data and some type of clustering method, and this is where you're seeing more and more machine learning based methods, and say these are the segments that come out, and these are the group types of individuals based on their utilization patterns that we think are important. And sometimes there's a layer, which I have here in a dotted line, of experts feeding in. So maybe there'll be a intensive data-driven approach, and then experts will say, well, this makes sense, this doesn't, and then it'll go back through an iteration. And so these are becoming much more popular. They have the advantage of not being constrained with a particular idea to begin with, but actually really trying to understand patterns. Perhaps they're going to include variables and data that you wouldn't have thought to include. And they're possible now because we have the volume of data and the methods to be able to do that. And both of these can also be translated into predictive approaches. So not just here's your population now, this is what they look like, but this is what they are going to look like, or what they're going to cost, or their trajectory in 5 years or so. So that's a sort of generalization, and I'm working on a project right now where we're actually comparing these approaches, including some new data-driven approaches with some existing ones to see what benefits they offer. Because I think on the surface, they're interesting. We don't have a lot of comparative empirical evidence to say, well, this one actually functions better when you implement it, and why. So that's what we're hoping to get out of some of the projects that we have planned. Now, inherent in everything that I just said about these approaches, for the most part, they're relying on transactional data. That's, routinely collected health data that's being used for the purpose of record keeping. And we all recognize that the data that we feed into our segmentation systems might be limiting what we do on the other side. So I'll talk about what we do with the segments once we generate them, but if we're only feeding in part of the picture, then we're going to think of solutions that are based on, generally speaking, the picture that we're seeing, and potentially miss things. And in particular, the things that we're missing are patient perspectives. So never in these segmentation approaches is there any ability to formally integrate patient perspectives, which we know will have a huge impact on the result of an intervention. So you can have a beautifully, integrated care, multi-specialty intervention to give that complex patient, but there's a chance they either are unable to take up that intervention, or not willing to, or have other reasons that are important from their point of view why it's not going to work. And so it's, at the end of the day, you're going to implement it, it's not going to show an impact, but perhaps the patient perspective could be useful there. And really looking forward to working with Carrie Kluski, my colleague at IBH, where we're going to try and understand patient perspectives on segments, just to try and get an initial thinking of what could that possibly look like. And I think this also builds on the many, many initiatives that are happening to try and get routine data on patients' perspectives and patients' points of view. We're also missing detailed clinical data. So many of the clinicians in the audience will say, you know, these segments are useful, but I actually need to know, you know, if it's a clinical intervention, there's more detail that's needed there. And so that's not being fed in. That could be very limiting, particularly for certain conditions. And, you know, we're largely missing socio-demographic data. They're starting to make their way more into segmentation approaches. But even about 10 or 15 years ago, it would be very unusual to have a socio-demographic variable in a segmentation grouper. And now they're starting to make their way in. So that's bringing us to data. So what's usually in these segmentation approaches, having reviewed them? Well, most commonly, it's all the things I've told you about. Sometimes you will have sex included and age, drugs, etc. Sometimes, again, we're starting to see an area-based socioeconomic measure. You know, in the UK, it might be the deprivation index, or here we might have sort of on marge type of thing, or you know, the income of the DA in which they live, which might give some granularity to it. And I do remember lots of discussions on some of the new segmentation methodologies on why it was important. You know, many feeling that we shouldn't include it because it didn't really make sense, doesn't fit into the paradigm. But now, of course, I think there's much better understanding of how, even if someone has no utilization, just the area in which they live can actually have a huge impact on their trajectory. Some of them, segmentation approaches around the world, use a little bit of a richer of EMR or EHR, and you might have some more detailed clinical information like blood pressure measurements or BMI, or even other information, and you might have some risk factors like smoking. I've seen that in some of them. But almost never do these segmentation approaches rely on data that include the long list there: gender, race, ethnicity, individual level SES, occupation, physical activity, diet, social support, environmental factors, community characteristics. So we are building a segmentation approach using data on the population, but almost never including these factors into that segmentation approach. And so why is this potentially a problem? So the first reason it's a problem is it because it potentially limits the whole population approaches. If there are variations in segments based on occupation, for example, and other considerations, it really limits what policy level factors could be implemented in order to lift the health of the entire population. And so, because we're just not considering it, we're not considering it a segmented group. And I always use the example of the never users of healthcare, or those that have very little interaction with the health system. And in fact, how much variation there is in their health outcomes, but it's not tracked because they haven't stepped through the hospital doors, or they don't have a family doctor, or they, for other reasons, have not gone to seek care, and we're just missing them altogether. And we're missing the opportunity for those macro level interventions. There's also the equity considerations. I've said this a couple times, so that even within a segment, there could be very wide variations on how individuals will respond based on some socioeconomic factors. And we are, generally speaking, limiting to actions that fall within the healthcare institution. Generally speaking, we're talking about individuals seeking care, the type of care they receive, and then trying to use that to inform what we do, when in fact, maybe what's needed are community factors, or social support, or minimum wage advocacy, or paid sick leave. And so it's not to say that the health system is responsible for all those, but the health system will feel the impact of those things. And so by not understanding them, we might be missing an opportunity to influence, or at least understand how important those factors are on influencing what does eventually come through the doors of the hospital. So this really kind of hit home for us when we decide to look at high users of the healthcare system in a bit more detail. And so many of you are familiar with Walter Woodchus and others' work on characterizing high cost users or high resource users of the health system. And we took that concept and linked individuals that had Statistics Canada, Canadian Community Health Survey data. So we had a fairly big cohort where we could really dig into some of these factors: demographics, socioeconomic, and health behaviors. And by linking this, we provided a perspective on high users that we hadn't seen before because it hadn't been in the routine administrative data. And I'll never forget when I started this project that there was a big meeting downtown Toronto on high users. This is, probably over a decade ago or about a decade ago. And we brought up this, we hadn't started the project. We were going to start the project, this idea. I think we had some early findings. And anyway, the meeting ended and there was lots of discussion on what to do about high users at this meeting. Lots of great ideas, lots of talk about improving quality of care. And then I left, and I think the person had thought I left the room, and I came back, and the comment was something along the lines of, well, it's all well and good, but how are we supposed to affect these socioeconomic variables? Like, I have enough to worry about. Those things are out of my control, something along those lines. And I wasn't upset at the person for saying it, but it was an important take-home message for me. I replay that many times because I understand how overwhelming it may seem to say, actually, it's not just about their past visits. It's about so much more. And it's just overwhelming. It's an overwhelming construct, and I get that. That being said, 10 years later, nobody would question the fact that we need to consider socioeconomic status as an important indicator of future healthcare utilization. And I think we've moved on to that. The question is how, and how can we make sure our health system is supporting that, not solely responsible for that. So with this work, and I won't go in tons of detail, one of the big findings was the magnitude of the socioeconomic gradients actually that we hadn't been able to see before. And the food security, which is, one of the biggest, oh, sorry, someone's, yeah, okay. Food security, which is, one of the strongest indicators of poverty and its strong relationship with high cost use. But not just socioeconomic factors, we looked a lot into health behaviors, and this really related to a lot of the chronic disease prevention work that many health units actually do. That's, a big majority of their work is focusing on chronic disease prevention, policy initiatives to improve chronic disease prevention, and how important that was. Before these trajectories start, before that multimorbidity kicks in, what interventions are responsible there, and of course a huge role for primary care. And again, just another huge reminder of the disparity we see. And so when you look at a graph like this and say, okay, well, there's a huge gradient of things like COPD, diabetes, which we know we have prevention tools for example, and they're disproportionately affecting those that live in low-income areas. What can we do from a population health management perspective, and how are these actually built in? And even taking it a step further to things that really reflect how people feel in their community. And this, we started looking at life satisfaction, which is actually a very robust indicator of how people feel in their community. It's a function of their employment, their relationships, their health. It's not about income, because you can be actually very satisfied with your life and not have a high income. But it's about being well supported, a feeling you have a voice, feeling that you're not left behind. Those are the factors that really influence life satisfaction. And we found huge associations with chronic disease, death, avoidable hospitalization, and healthcare use. So all of this to say how this idea of feeding into a segmentation approach with a broader data perspective is where I think we need to go. There's lots of talk now about what an electronic health record needs to be to truly facilitate population health management. And there's a little bit of discussion, and I would hope more, on what else needs to be in there and how does that relate to how people are in their community and what are the factors in their community that support that. And you have, you know, visionary figures like this saying that to do segmentation, we're actually going to get lots more detailed clinical data. We're going to know about their environment, their behavior, social interactions, and that's the electronic health record that's going to enable true segmentation. And this is just another graph on that. Okay, so for the last few minutes, so we've talked about who's the population, we've talked about what are the different segmentation approaches, and then what data are they based on. And now I just want to spend a few minutes talking about, once you have those segments, so perhaps there's more balls going into this funnel here that actually capture broader data, what do you do with them? How do you actually take those segments and inform action that's more optimally serving the population that you are accountable for and responsible for? And for this, I just want to draw a little bit on our experience with a project that focused on building a series of risk tools, known as population risk tools, to inform future health planning. So these are tools that we build on routine collected data. We largely had public health units in mind, but provincial governments can use this as well, and they could estimate future burden either of multiple chronic diseases or high cost use. And so what I'm going to talk about is really about what's the key learnings from actually putting a tool like this. So this is just one example. You can think of it like a segmentation into practice. And in particular, we had a tool that's looking at high resource users. Again, we base it on sociodemographic and health behavior information largely. So it's kind of the opposite of a pure admin data tool. And, you know, looking at that variation that exists at the population level. And here, just an example of how that varies. In Ontario, you can see how much it varies, and this is in specific subgroups. And you can start getting into particular clinical subgroups, but the most common when we think of high resource users of healthcare, you know, older adults with multimorbidity, or like as a contrast, can you just think of individuals not defined by disease, but actually think about it from the risk factor perspective? And what does that look like? So key learning number one is the challenge in considering distributions. So the one big change from thinking about individual patient management to health system management and then to population health management is the importance of considering distributions. And of course, I'm very influenced by Jeffrey Rose and the work here, but it's a really hard concept to actually explain, especially when you have a system that's built around individual interactions, on why it might be important. So the idea of looking at, when we get questions like this is related to our diabetes tool, the idea of actually showing distributions and actually making sure that you're managing both the individual and the distributions at the same time. And so when we were focusing on diabetes prevention strategy that different regions were interested in implementing, you know, overwhelmingly diabetes prevention strategy are focused on individuals that are high risk. They're a high risk because of a BMI category, or even a high risk within that group, and then intensive targeting at those individuals. When in fact, the majority of cases of diabetes were not happening among those individuals of high risk only, they were happening across the distribution, which supported the idea that a population level intervention that affects many people, that's less intensive, would also be beneficial. Not that you need one or the other, but that you need both. Also for high cost users. So again, when we think about managing high cost users, when we look at this is the risk. So when someone has 8 or more chronic conditions, their risk of becoming a high resource user is very high. That's not surprising. But there's lots of people that are in the 0, 1, 2. So if we're optimally managing our population, what are we doing for these high individuals, as well as thinking about prevention or mitigating the future impact of these individuals that still contribute actually most of the high resource users in the future, because that trajectory will continue unless we put measures in place to stop it. So this is the type of thinking. That's just another example of it. I also just want to say one more thing about the high risk approaches, which I get really worried about on the implementation side if we don't think about distributions. That is, if we focus in on the highest risk and the highest need only. So first of all, the contribution to population health impact might be small. And actually we see this with a lot of interventions. Some really well done, smart, important interventions to improve health in high risk individuals. And then the evaluation's done and the impact seems small. It made a difference for some individuals, but not all. And it's not because the intervention didn't work or wasn't important. It's because it was the only intervention, and it probably needs to be coupled also with population-wide approaches or some other approaches. So the idea of thinking of a basket of interventions that need to be delivered for population health, which I know is complex, but will help us, in the right direction. It doesn't mean one person has to do them all. The different players in the system are responsible for different aspects. The other thing I worry a lot about is the potential for increasing inequities. So if we start focusing in on very narrow populations and only some individuals within those populations benefit, can actually widen inequities over time. And we've seen examples of this a lot. And Ontario has actually been, the inequities have been widening in Ontario, depending on which health outcome you look at, but taking some of the more robust ones like premature mortality or some of the chronic disease composite outcomes, the inequities have been widening, despite probably care is getting better for some individuals, others are being left behind. And so just the importance of considering that in the implementation side. And when I presented some of this to one of my colleagues who I work with on the method side, so he works with some of these machine learning approaches. Again, he's from the business school. From a business perspective, he shared this paper with me, which I thought was really fascinating, about how from a marketing perspective, it's starting to be very well understood that you have to understand the response to the marketing action, or in our case would be the response to the intervention. And so once we develop these risk groups, how well are we understanding how people are going to respond within those segments? And this paper actually shows mathematically that when you do that, the risk line here is this one line that's going straight down. You do not see the benefit equally, whereas you have a much bigger treatment effect, which is a response to the marketing in this place, if you actually consider who's likely to benefit in those strata. And some of the data elements I spoke to might actually give you the ability to do that. So in summary on this part, when we think about going from segmentation approaches to impact, sort of like these three questions I'm always asking myself. What data are we feeding in? And what are the implications of the data that we're not feeding in? I'm a realist. I know that we're not going to fix all of our complex data challenges in a day, but at least if we have awareness of some of the things that aren't being measured, or we can start putting things in place to try and improve that, that will make sure that at least we're aware when we implement it. Who does it apply to? Are we just talking about that dark blue pie and then forgetting about the rest of the population? If we do that, we will not see an impact. That's not what population health management is. Population health management is about this whole pie. And so what do these lighter blue people need? And what do the dark blue people need? And it's not all in the health system. So that's the other thing to keep in mind. And the last one is speaking to that again, is how is it going to be used? If it's going to be used to only target very specific high risk interventions, then we are doing some good work to improve the quality of care for those individuals, but not population health management. And just checking the time. So a couple more minutes, then I'd love to have a discussion. The last thing I'll say, just from my experience with working with these population risk tools as well, and this applies to the segmentation approaches, is that we have to be quite intentional about it. So we actually we developed a knowledge translation framework that builds off Graham's knowledge to action framework to say, when you develop a risk tool to be deployed on populations, there's some really key pieces. I won't go through all of them, but this one here, the build capacity for tool use. So we actually went into organizations and taught their analysts to run the risk tools themselves. And that was important for two reasons. One, so that you got rid of a barrier of having access to that information. And two, when you build the capacity within the organizations, they're much more willing to use it. So you don't have to just come to me to run the segments for you and go off, but it's not a black box anymore. You know how it works, you know what you can do with it, you can play around with it yourself. Even if you're not going to be running it on a routine basis, that building capacity in the institutions was critical. And then, of course, the sustaining the tool use piece. So it's not just, here's this segmentation method, fancy method, it's great, away I go. There's lots of questions after. How do I use it? Am I presenting it right? Can we use it this way? Can we stretch it in this corner? Because of course, all the OHTs are going to interpret them and then use them in different ways, which is a good thing. And they're going to maybe push it in different ways. So there needs to be that sustaining piece thereafter. And then the last thing I just want to say on this was there's not one person that does this. There actually needed to be a team, someone with in-depth technical knowledge of the segmentation to support the technical piece, but also the conceptual piece, and obviously the importance of evaluating it to make sure it can be tweaked as we go along. Okay, this is my last slide. Catherine, did you want to say something? Okay, I'll just keep going. So what did I just say? Here I'm boiling it down to a few recommendations, and obviously simplifying a bit, but hopefully the thread comes through, and these are the main take-home points. Before we really embrace population health management in this province, which I'm very excited that we are, some considerations. So first, defining the population. So let's actually talk about it. Let's think through the full implications of the definitions that we're using. I'm not talking about overanalyzing it, and I fully appreciate the let's start somewhere, but maybe in version 2.0, we should consider a different definition. And that version 2.0 should be informed by patients in the community. And I believe they need to have a bigger voice in understanding actually how we define a population. I think they would tell us very differently than our vantage point, what's important to them. Secondly, I think I've beat this point over and over about how we have to start thinking about distributions. And if we're moving to managing a population, we need to understand how distributions work, and we need to understand what that means in terms of benefiting the population, and be very careful about the potential of increasing disparities, which is a very real side effect if we don't think in distributions. Broadening our data assets. So in particular, our data inputs are narrow. I think many people understand this. So it's not disparaging. These are the data systems we have. The question now is, how do we start broadening it? And this might mean going to emerging data sources and creative ways to capture data that we have never thought of before. And now we have new methods to do that. On the implementation side, integrating the segments, clarifying accountability and resources. So I'm very well aware that one of the implications of what I'm saying is that there seems to be a lot more things that we might be accountable for than we have levers for. So if we're talking about some of those broader factors, some of the structural factors that we know contribute to health inequities, let's clarify who's responsible for it and what role the health system plays in partnership with others. And I think that's an important discussion. And then lastly, I didn't have a lot of time to demonstrate this, but I mentioned at the beginning, the vulnerabilities that we're seeing as a result of COVID were completely predictable. They're not surprising in any way. to anyone that understands population health and how what happens in public health emergencies, and actually has happened since we first understand infectious disease outbreaks with John Snow, because the people that were affected in John Snow's first outbreaks were those that were in high-risk occupations, living in dense and crowded household, and mostly disproportionately affected by poverty. So it's very well, we know it and we can predict it. So now the question is, how do we build that in? How do we build in resilience concepts? This is an underdeveloped area that I think would really benefit from some thinking both on the data and the measurement side. So that's it. I just want to acknowledge my lab and my co-investigators on the segmentation project, pictured over at the right, and very happy to take questions.
Thank you, Laura. I could sit here and pick your brain for just you and I for the next hour, particularly around all of the data that we are not feeding into the system. I mean, this couldn't really have been more timed perfectly as we are digging into our OHT. And, you know, we just had an evaluation committee meeting earlier thinking about, you know, what do we need to measure that's important for us? And I love, you know, I'm going to go back and read the paper now about performance management, the overview of trends and looking at societal value, because I feel like that's where we're at. I'm going to open it up before I ask you a few of my questions, because I imagine a number of people have some for you. If people want to unmute or pop them into the chat, and I just want to say and echo Helen Cooper's comments, how easily this was to understand, and we will be using this presentation as a foundational resource for the OHTs.
It's fantastic. Great comments. And thank you also for bringing up the health strategy, Premier's Council on Health Strategy document. Again, like many of these ideas have actually been around and very well and clearly articulated in a lot of documents, a lot of provincial documents.
Mm-hmm. I mean, I guess the thing is that if people don't have questions, again, I'll start with mine, but please, if other people have them, just unmute. So it's always tricky because these have been around for a number of years, and you know, you're seeing people accepting that we need to measure them. But I guess the question is just grappling with, and you know, how do you get at these emerging data sources? And also, how do you talk to policymakers for them to recognize that that needs to be in the core data set?
Yeah, great question. So my answer to both of those, I think, it really goes back to giving more of a patient voice to these, because I think the patients will tell the policymakers and tell their physicians, any physicians on the line all the time, about, you know, their challenges beyond what's recorded as for a billing or administrative databases. And so I think if we really take those conversations seriously and start opening it up, that would be critical. I mean, there's a couple practical strategies. So one would be, do we really expand what's collected as part of our health card number? Right. So are there some, which most health systems do, so that if you're part of a US insurance system, your base demographic database includes actually quite a bit of information about you, not just your age and sex, which is pretty much what and maybe your postal code, which may or may not be updated on a regular basis. So that baseline demographic database to which we link all these things through, I think there's some fairly easy way to enhance that. And then the other piece would be in the electronic health record as they become more sophisticated and more digitized and linked to environmental indicators, for example. There's an opportunity to actually make some of this routine in that database.
Yeah, I've been giving it more thought, but you know, I think, you know, the EMR is at the primary care level, and I mean, there's lots of, it's fraught with challenges with so much diversity at that point. But I think the billing, the OHIP, and you know, using that structure, because you know, right now we've got institutions, but the non-physician members of the healthcare system. I mean, that I think tapping into how to use those OHIP structures to routinely capture that data, that I think that starts to get at these emerging data sources and societal community impacts. So I'm taking over with questions. I'm going to stop talking. I could really talk to you for a long time. Is there anyone else?
Oh, sorry. Yeah, if it's okay, if I could jump in. I just have a couple of quick questions, hopefully. So going off, I guess, what you two were talking about using like new data that we can incorporate into OHIP and stuff, I wanted to talk about how you're mentioning how like socioeconomic data and stuff isn't included. And I was wondering if it was completely unincluded or if there was any unstructured data included, and whether you ever thought about using things like natural language processing to kind of scrape health records that way.
Yeah, you're absolutely right. So that work is happening, not as much in Ontario because we have lots of EMR systems and all this stuff. But let's just picture a place where there was one electronic health record, and some of the US situations that's the case. And in fact, that's exactly what they're doing.
Mm-hmm.
So it doesn't have to be as hard as we think, in that we have to like create a data field and figure out, but it actually can be mined from the existing record. And they've been doing things like looking for people that live alone based on what's written in the text to identify social isolation, which we know is a critical need factor for anybody that will be dealing with chronic illness. So, or, any other, caregiving responsibilities that they might have. So that is actually being done in other jurisdictions around the world. And you are absolutely right. This isn't about doing all the work and creating this, but can we leverage some of these methods to take what's already collected in that database?
Yeah, no, I've seen some really cool research on that as well. And so kind of slightly unrelated, but hopefully tangentially, you were talking about high-risk patients. They were kind of caught more often, or like, a bigger focus for a lot of healthcare workers. Do you think there's any aspect of high-risk people being easier to predict because they might have multiple comorbidities? Because my experience with machine learning, and like you were talking about earlier, it's usually kind of expert opinion that informs like the variables or features in the model. So do you think as we transition to maybe using more like clustering and data-driven approaches, that we might be able to predict lower risk people more often and be able to provide them that intervention?
Yeah,
potentially?
This is an excellent question. This is one of the reasons I'm actually really interested in the data-driven approaches, because it'll take our blinders off. For sure, the approaches that we're using now, if you are already in the health system and you have care and you're seeking care, we're going to pick you up. And those that might have barriers to care or not seeking care for lots of reasons, maybe they face discrimination when they go, so they don't go, or they have other access issues, we're missing them completely. So this is why it's really critical to try and understand, and a data-driven approach might actually pick up those individuals. And this is why I actually think that these methods are the way forward. I think there needs to be an expert overlay to make sure, these are, we're not picking up some unusual things, and we're going to pick up bias as well in the health system. But you're absolutely right. The ones that are the one I showed you, the prediction model we have, is actually based a lot on sociodemographic characteristics. So it might be overcoming some of the limitations on the admin only ones, but it's a great question.
Awesome, thank you.
Thanks very much. Well, time for one other question. I don't know. I saw a few people put their video on. I don't know if anyone has a final last question.
I have a question. I don't know if it's interesting enough to be the very last question.
Pressure.
Thanks for the presentation, Laura. That was very interesting. And very engaging as well. You did a great job. I'm interested in, you mentioned health behaviors as a concept that we need to sort of do a better job of capturing in the data. What I'm interested in is sort of how we then use that to implement behavior change techniques that are sort of population driven. Is that something, I'm not sure if that's something you wanted to discuss, or do you have other strategies that as successful, or
no, I want to bring it up actually. I thank you for asking, because a health behavior, let's just take like a physical activity flag that comes up, it has multiple implications. So when I work with public health, all of this is feeding into broader chronic disease prevention strategies, making cities more walkable, making sure that children have access to parks and safety and all that stuff. But at the same time, it's also really important for our primary care provider, who might want to implement behavioral intervention that's, has lots of evidence around it and can facilitate that individual interaction. So it actually has multiple implications. And I think one of the challenges is we only think about one or the other. We think like, well, I have to go focus on the individual. Actually, both things need to happen. You don't reduce smoking rates, for example, by only focusing on individuals or putting in bylaws. You have to do both. And that's what population health management is.
Great. Thank you.
Thanks very much, Cal. That was an excellent end to the discussion. And Laura, thank you for talking today and really making this topic accessible. It couldn't be a better time, as I've mentioned. Thank you to everybody, and this will be posted on the HSPRI website and YouTube.
Thank you all. Thank you for the invitation and
Thank
great
you, Laura.
questions. Thank you. Bye-bye.
Bye.